So, a very good evening, guys. So, we are starting our day with one of the very important clinical case in field of medicine, and especially when you are under training, uh, rheumatic heart disease. It is a long case as well as a short case. Apart from this, especially where we are living, a country like India, the developing nation, we need to know how acute rheumatic fever manifests and what are the criteria. So we are going to cover this topic in multiple series, but today we will start with the one of the main thing, what is the criteria for it. That is called Jones criteria. Now, Jones criteria consists of two things. There are major criteria and minor criteria. Before starting this, major criteria, when we cover major criteria or minor criteria, important thing is it took population in picture, whether population is at high risk or moderate oblique low risk. So it becomes very important when we are putting or applying Jones criteria in the population, where the population on which we are putting it or applying it, is it at low risk or moderate or high risk. So it is moderate or high risk. So what is the criteria it is? Now, low risk population is where the cases of acute rheumatic fever incidence is less than 2 per 1 lakh. So we will remember there's two things here. First criteria is incidence of acute rheumatic fever in population less than or equal to 2 per 1 lakh population of school aged. So it is very important. The student, we have to see school age children. The second is in this criteria is saying which is related to all age, and that is RHD frequency less than or equal to 1 plus 1000 population. So when we are going to put Jones criteria, first thing we need to understand the population dynamics. Now, population dynamics can be low risk and it can be moderately and high risk population. So what is the low risk? The criteria for the low risk has been set up, and they are like acute incidence of acute rheumatic fever less than or equal to 2 per 1 lakh school age children, or if you're considering the complete population, it has to be one case of rheumatic heart disease or less per 1000 populations. They come under low risk population. So this become very important. We need to know first define population dynamic, low risk, high risk. Now let's go back to our criteria. Now criteria, first we cover major criteria. Now major criteria are, number one, we have to see for carditis. Now it is carditis is risk factor for both population, whether it is a low risk population or moderate and high risk population, as we have already covered. So carditis is one of the main criteria which comes under major criteria. Then arthritis. Now in arthritis, when you are covering, if you are looking for low risk, again, can you explain me what is the low risk criteria as per the guidelines? It is less than or equal to 2 per 1 lakh children school aged or school going children. Cases of acute rheumatic fever. At the same time, if you are considering the population, you have to see rheumatic heart disease cases less than or equal to 1 per 1000 population. So they come low risk. In low risk criteria, you have to see in arthritis, polyarthritis. In moderate oblique high, you can even consider monoarthritis as major criteria. So that become very important. In a low risk population, it is polyarthritis only. You can't consider monoarthritis as a major criteria in a low risk population. And but if the population is moderate and high risk population, you have to consider monoarthritis. Even you can consider monoarthritis as a major criteria. Polyarthritis will remain a criteria. There is no doubt about it. Apart from this, you have to also consider in those guys polyarthralgia. So even the joint pain is also a major criteria in a moderate and high risk population. Okay, but it is a major manifestation in high risk. That is very important, and after exclusion of other causes. So basically, when you are considering this thing, you have to exclude all other causes. Now we will come to the third criteria. So we have covered carditis, we have covered arthritis, then chorea. Chorea is again common for both the risk factors. If it is present, it is a major. Fourth thing is erythema marginatum. Fifth is subcutaneous nodules. So we have all 5 criteria here. First thing, before putting a major criteria or minor criteria, we have to differentiate the population in low risk and moderate and high risk population. So low risk population criteria is if the incidence of acute rheumatic fever less than or equal to 2 per 1 lakh school age children, or if we consider the complete population, it has to be rheumatic heart disease incidence less than or equal to 1 per 1000 population. So when we put major criteria, the only difference between major criteria for the high risk or moderate or low risk is in arthritis. In low risk population, you have to consider polyarthritis only, but in moderate and high risk population, you can even consider monoarthritis as well as polyarthalgia, but we have to exclude all other causes of it. Otherwise, the other major criteria are carditis, chorea, erythema marginatum, and subcutaneous nodules. So we have now covered all the major criteria of it. Now little bit of explanation for the different manifestation in RSD, what we have covered in major criteria. Before this, we will cover minor first. After minor, we will discuss a bit about all the manifestation which we have discussed in the major criteria. So first, we have covered major. Now second is minor criteria. Now minor criteria is again we have to consider the population, whether it is low risk population or a high risk population. Criteria I have already explained, so I will not repeat it again here. We can revise it at the last. In low risk minor criteria, if the population is low risk population, is polyarthalgia. So what is the difference? Polyarthalgia in low risk population is a minor criteria, but in more high risk population it is a major criteria. So here monoarthalgia, single joint pain, is a minor criteria. Second is fever. As we know, it's an acute rheumatic, it's an infective disease. The patient can have fever, but here again the criteria differentiate between low risk and high. In low risk, the fever which they are taking is 38.5 degrees Celsius. Remember, why? However, in high moderate risk, it is 38 degree Celsius only. So 0.5 degrees Celsius differences between low risk and high risk population. Third criteria, ESR, that is erythrocyte sedimentation rate. That they also consider 60 mm in first hour. However, ESR is more than 30 mm in high risk oblique moderate risk population. So there is a difference in fever temperature criteria. The polyarthalgia criteria is minor for the low risk population. However, it is a major criteria, if you remember, for the high risk population. Now fever 38.5 degrees Celsius more than or equal to is minor criteria for the low risk population. Fever more than or equal to 38 degrees Celsius is for the minor criteria for the high risk population. Now when you consider the ESR, you have to see 60 mm in first hour fall is minor criteria for low risk population, while more than or equal to 30 mm is per hour is for major population. The other investigation which you can also do, CRP, which is 3 milligram per deciliter for both. There is no differentiation in CRP when they consider CRP more than or equal to 3 mm. They have considered it for both minor risk as well as major risk population. Now, it is also very important here, I will explain. The CRP value must be greater than upper limit of normal for laboratory. So basically, it should be more than upper limit of normal as per labs. Because ESR may evolve during the course of ARI. Peak ESR value should be used. So whenever you are considering ESR in the course of illness, it is the peak which you consider. Now we come to the last criteria. That is, you have to do a ECG. You did a ECG, then you see for the PR interval. So now the importance of ECG, you can answer why ECG is important. In acute rheumatic fever, it is a PR interval which we have to see. Now, prolonged PR interval is a minor criteria, and you have to consider as per the age. And here you have to also see whether the carditis is already there in the major criteria or not. If it is there, it is okay. You don't have to see the variability. But prolonged PR interval is a minor criteria for both high and moderate risk population. If carditis is absent, you can have to consider prolonged PR interval. So important is that carditis is not present in major, then only you have to see this criteria. So let's revise the Jones criteria, or what are the major criteria and the minor criteria. But before coming to the major criteria or the minor criteria, we have to understand the population is divided as per low risk or the moderate and the high risk. Criteria for the low risk population is acute rheumatic fever incidence less than or equal to 2 per 1 lakh school age children for all age, and for all age group, if you see the rheumatic heart disease prevalence of less than or equal to 1 per 1000 population is the your low risk criteria. So when you consider the major criteria for the low risk or moderate, carditis, clinical or subclinical for both as per the 2D co-finding or the clinical aspect. Arthritis, when you consider it for my low risk population, it is polyarthritis only. For moderate or high risk, it is monoarthritis, or as well as you consider polyarthalgia. Mind it, when you are going to see the minor criteria in that low risk population, polyarthalgia is a minor criteria. Now chorea, erythema marginatum and subcutaneous nodules are the major criteria for the both risk population. Now when we come to the minor criteria, again the low risk and high risk, the difference is polyarthalgia for the low risk population is a minor criteria. You remember when we discussed the major criteria, it is a polyarthalgia for the high risk population or moderate risk is a major criteria. And the other thing which you need to know, you have to exclude other causes of the polyarthalgia. Second thing, when you consider fever, the temperature is also set high for the low risk population, that is more than equal to 38.5 degrees Celsius. For fever for the similarly moderate and high risk population, it is just 38 degrees Celsius. Third, ESR. When you consider the ESR again for low risk population, you will see more than or equal to 60 in the first hour fall. While for the high risk and moderate risk, it is 30 per hour. CRP is same, that is more than equal to 3 mg per deciliter for the both the criteria. The only thing which you have to remember, the value must be greater than the upper limit of the normal for the lab. Last thing, ECG finding. That is a prolonged PR interval, and you have to see the age variability. But here, caution, it is a minor criteria for both. But if the patient is already having carditis, you don't have to check this thing out. So, are we clear? Here we end our Jones criteria. Now, how will you diagnose? So, the whole criteria concept is for diagnosis. Now, we know what are the major criteria, what are the population based criteria, what are the minor criteria, but how will we diagnose? The question is still same. So you have to see, or it applies to all the patient population with evidence of preceding group A streptococcal infection. So here the word is evidence of previous or preceding group A streptococcal infection. So you need to ask the history also, ask the patient so any history of pharyngitis or throat while in childhood. There, the diagnosis, when you consider initial ARF, you will see two major manifestation or one major, sorry, it's my mistake, sorry, it's one major plus two minor. If patient has again ARF like feature, so when you consider a recurrent ARF, you have to see two major, one major plus two minor, or three minor. Even if the patient is having no major manifestation, three minor is also to be considered in recurrent ARF. So we now know the diagnosis, but the important thing is that you have to check in population whether the evidence of preceding group A streptococcal infection is there or not. Thank you so much.